So the reason that we have these 3 volunteers up is that this summit is more about taking the information that you've seen and using it locally to do some improvement and action on things that will have most impact for your patients, which is why we've sort of brought it down from the statewide, put you in your ICS to have a think about what really is going to work locally. So we know that many of you are involved, as per Catherine's presentation, in a lot of the work around the state to improve various steps along the cancer pathway. So these 3 volunteers are just going to share really briefly about some work that they initiated. I won't say totally as a result of the last summit, but certainly I think that seeded the conversation. So I'm going to start ladies first. All right, so now Zee, you had also a couple of other people helping you with it. Just right? No, I haven't got those names here. So first of all, I'm going to say, really briefly, what was the project that you were involved in?
So about 6 months ago at Peninsula Health, we had the opportunity to look at how the GI MDTs were running, the quality of which was being examined in terms of the surgical presence at the MDT, as well as the timeliness of the patients being presented at the MDT, because most often, as we experience that we have a lot of patients to present, we exceed the 1 hour that we need, and then the patients then spill over to the next MDT. Yeah. We run the MDT once every fortnight, and really it was a combined GI MDT with upper, lower, colorectal and hepatobiliary, and the numbers could go up to 18 within an hour, which is quite difficult to get through for all of us. So as a result of that, we had the opportunity to engage the surgeons, the colorectal surgeons in this case. At the same time, we had the help of the MDT coordinator who actually ran and looked at the audit of all the cases presented at the GI MDT over the last 6 months or so. And we're able to tease out the colorectal cases and the upper GI hepatobiliary cases. They were about a 60-40 split. We discussed this on 2 occasions at two of the GI MDTs to all the attendees. And then we did a bit of a poll, and the consensus was we should split the MDTs, to improve the timeliness of presentation of patients and for surgical presence so that the colorectal surgeons are able to come to a colorectal MDT. So that was exactly what we did. But it was not without effort. It was a lot of hard work and commitment and determination to make it work. And I think that I represent the people behind me who were actually who gave their time and their effort to make this possible, and I'm grateful for that. I think we also had to engage the executive, which is really important. We had to have their buy-in that this is really necessary. We had to justify for the increase in workload for the pathologists and the radiologists because it was a contracted service. And at the end of the day, I think everybody was happy. We managed to run the first colorectal MDT separately from the upper GI hepatobiliary MDT in January this year. I think it was a huge success. We had a good presentation from all of the different stakeholders. And I think what was also important to realize is that we gave the ownership of the MDT to the colorectal surgeons. Yeah. So they chair the meeting, and I think from there we could get a cohesive group of people to say, all right, this is what we own and this is what we want to make it work, and it's a quality MDT.
Fantastic, thank you. And so you pointed out really clear need to change, obviously. Consultation of all involved. So you thought about the circles that we had before. You knew you had your key group who were keen to help, but you obviously built the relationships with the executive, with the the rest of the stakeholders, and you didn't hurry it. You took your time. You had your data, got it together. Yeah. What would you do differently?
I think looking back, I must say that we started with a lot of trepidations that it was not going to work. Yeah. And I think, would I do it differently? I would probably do it very similarly, I don't think, but perhaps have the exact engagement earlier on. Okay. Because we did have a few roadblocks along the way, even with the data we had, with the number of patients being presented at the MDT. In terms of trying to have another meeting in everyone's really busy schedule to find the venue availability and the time spot that will suit most people, it's a difficult ask. Yeah. But I think having the executive engagement was important to try and get buy-in from the various stakeholders, which was helpful to try and push us beyond that hurdle. Yeah. Okay, thanks, Zee. Very good. All right. Brian, you are up. So, Brian,
why did you do the project that you did? So tell us a little bit about what you did and why that was important.
So I need my cheat notes here.
Cheat away.
So first of all, I think it's not my project. The primary author was Michael Franco. I was involved, but he was the primary driving force behind this. So what happened is we had a bit of discussion after the first summit about MDM and how we could make it better. And one of the things we noted was that there was a lot of changes in the reporting, I mentioned this earlier, of radiology and pathology that occurred at our MDM. And what we thought we would do is look at how often that happened. And so we simply prospectively collected 150 patients from our colorectal MDM over 10 meetings. And we had a scribe recording whenever there was an impact of that meeting on the radiology reporting or the pathology reporting. And there was the impacts of the changes were then graded as either nil, so if that made no difference at all to the treatment of the patient, or minor, if the change in reporting either reinforced a treatment decision or perhaps gave it less weight, or major, when the change in reporting changed the treatment plan. And I'll tell you the results.
Yep,
So 150 patients, 10 MDMs, 26 of 150, 17% of patients had changes to pathology and radiology reporting as a result of their MDT discussion. One patient had nil, that is the result of that patient's change of reporting had nil impact on their treatment. 13 cases had minor impact on their treatment plan, and 12 cases had major impact on their treatment. That's 8% of patients discussed had major impact on their treatment as a result of that discussion. So just to expand on that a little bit.
Yep, go ahead.
9 of those cases were radiology reporting and 3 of those were pathology reporting.
So, Brian, why did you work on that? You said it came up after the summit, so why that particular nugget of improvement?
Well, we had this inkling. Anecdotally, we thought there was something happening. It's a reasonably simple project to do, and we think there's a lot of value in the review and the discussion, and we wanted to highlight that.
Yep. Okay, and I think that's an important one, is to some of those low-hanging fruit, as they're described, things that you can see are going to make a difference. And now I'm sure that Brian and Michael and the team are feeling a little bit more enthusiastic about the next project, so, winding that up to the next one. So what did you and the team learn from that project? Well,
I think it highlighted what we thought was happening anecdotally was actually happening in real life. It reinforced the value of a robust inquisitory MDM with pathologists and radiologists who are prepared to give an opinion, which we think is really important. It also, I think, highlights the need for good attendance and good equipment. I think up until very recently, the equipment we had for our MDM was really below par, and I think you need good equipment so everybody can see the radiology and everybody can see the pathology and the treatment plan and see how it's recorded. The last point is that the patients, we did analyse the subgroups, and the patients most likely to benefit from an MDM discussion were those rectal cancer patients, and the most revised report was an MRI.
What would you do differently?
When you ask me that, do you mean what would I do differently at MDM, or what would I do differently
to get another little improvement project happening? What were the things that...
I think I have a real problem with MRI reporting.
Yep.
And I would like to see if there was a way that we could structure that much better, both from the point of view of the imaging itself, what imaging we do and how we slice it and how we reformat it. And I'd like to see, if it were possible, some sort of synoptic reporting for MRIs. I think that's
Okay.
my...
So in fact, what Brian is exhibiting is that he trusted his gut, or he and Michael and somebody else was there, Eric. So as experts, your intuition and your gut feel is a really good start for something, but you don't rely on the anecdotal, saying, oh, it always happens like that. You can take some information, you could challenge the current process, and you can find out if your gut is right. Right, moving on. Geoff. So tell us a little bit about your project and why you started that.
Okay, so this did arise from the 2014 summit, the original summit, which, amongst other things, we noted that the survival rate between ICSs was significantly different across the state, and I work in two different ICSs, being NEMICS and also GICS. So those two ICSs actually had a 10% difference in overall survival. So what we thought we'd do was to do a chart level audit of patients in a 5-year cohort at the two sites to see if we could identify factors which might be influencing the survival, and hopefully we might be able to identify reversible factors. So far we only actually have the... okay, so the next thing is to which group to target. So do we target patients with metastatic disease? Do we target early stage patients receiving adjuvant chemotherapy? So the first phase of the project, we actually looked at patients with stage 3 disease receiving FOLFOX chemotherapy. So we identified all those patients at Ballarat and also at the Austin. And interestingly, we found no difference at all, either in the survival of those patients or in factors which might impact on survival or might have resulted in a different survival for those patients. So what we're actually doing at the moment, and we've collected the data for just the Ballarat side at the moment, is to look at patients with early stage disease. So we're looking at patients with early stage colorectal cancer who did not receive chemotherapy. In terms of what data are we collecting, we're looking at really as many factors as we can think of. So we're looking at the patient's demographics, where they live, distance from the centre. We're looking at tumour factors, tumour stage. We're looking at treatment factors, so what sort of treatment did the patient receive? Was it surgery? What type of surgery? Whether they received... well, they didn't receive chemotherapy, but other treatment-related factors. We're looking at comorbidities, and also we are looking at timelines as well. Timelines from referral to being seen, timelines from presentation to surgery, things like that. So as I said, so far we only really have very preliminary data, really just from the Ballarat side. We did look at emergency presentations because in GICS the emergency presentation rate seems to be higher. And that was borne out by our audit as well. And we looked at early mortality, so these are very preliminary data, but we did see an overrepresentation of patients who had presented as an emergency and mortality at 1 year. So there did seem to be some correlation there, and would be consistent with the known poor prognostic effect of emergency presentation. So at the moment we're collecting, we've got in fact our medical student at the Austin is here today collecting the data for the Austin group. When we get those data, we'll be able to actually compare the two and see if there are various factors which are different between the two groups and whether these might be reversible.
A couple of things come up for me. The fact that you work across a number of organisations, and I suspect every clinical I'm going to say surgeon, oncologist, radiologist, pathologist, would work in more than one area. So to make sure that what you learn in one share with the others is obviously something that struck you as being the difference between where you work, and you've taken an interest, put something together that actually looks at where the differences may be. So what did you learn about putting it together? What were the steps that helped you get some runs on the board? So there would have been formal process, I guess, to get your research assisted. But what were some of the maybe the more tenuous, such as what Zee was saying about getting executive on board? Was it a hard sell to sell something cross-organisation?
Not specifically. I mean, this is an audit, so obviously we need to get audit approval. We utilising data from the VCR for both identifying patients, also for their survival. And obviously the manpower, we've had a succession of research fellows in Ballarat, and also we've got access to University of Melbourne students doing their fourth year scholarly selective, so that's been helpful as well. That was able to be done within their already existing sphere of work? Yes. Yeah. Okay. I think it's a great project actually for students. Yeah. If you do have access to students, whether it's from this program or another program, then that is it's mutually beneficial. It's beneficial for the student, and also it's beneficial for investigating for the wider sort of cancer community as well. All right. Thank you. So the panel don't know this, but I'm going to say, are there any questions that you would like to ask the panel? Excellent. Ian, and then down the back table.
Thanks very much. Great presentations, guys. They were fantastic. My question specifically is to Brian. Did you find that the variations in reporting you found came from results that came from your own in-house team, or came from external providers who'd done the MRIs or pathology at an external site and had been referred prior to the patient getting to you?
Both, but I think it's fair to say that there probably was more from an external site. And that's something I continue to notice.
Sorry, we'll go down the back first, thanks. Yeah.
Hi, it's for Brian. Did you find there was any reporting of the changes in any of the MDM records, or was it just pre and post? That's the first question. So if the MDM found, or the review found a change, was that recorded anywhere? That's the first bit. And the second bit is, do you think any of those should have been lodged as a VIMS, and were they, where there might have been some sort of change or misreading?
So there was recording of the change in reporting in the MDM record, and where the pathology or radiology was in-house, it was amended. I'm not sure that I've got an answer to you about the VIMS question. I need to look at it a bit more thoroughly. There was something else. What was the other? That's it?
That was it, yeah.
Again to you, Brian, I just wondered whether you have dedicated MRI radiological teams reporting on the primary report, the first time it's reported, as distinct from rotating radiologists who might be doing anything. That might be where the variation occurs between the initial and the MDM.
So there certainly is some rotation in the radiology department. There's fellows and there's different consultants reporting the MRIs. As far as the MDM reporting of the radiology goes, it's usually there's a single consultant, and there is a couple of MRI fellows who are reassessing the MRIs under supervision.
It's Neil from GICS. This question's for Brian. Sorry to overburden you with another question.
Oh, should I say the others could go? No, stay. Please say.
So there's always a question whether the MDM is the standard of care, or whether it's a best practice, whether it's mandatory in discussing these patients. You answered with your project very well for this question. Now, there is two sides of it, and one is whether we should overburden MDMs with all the colorectal patients, or whether we should be selective in patient presenting in the light of your new findings. Where is the middle ground at the moment? Or where would you think that will fall into?
So we're wrestling with this problem every week. So our MDM used to be fortnightly and it just became too big. It's now weekly. And we would have 15 to 20 patients per week. And what we've done is for the straightforward patients that people have been discussing before, we will mention them and they will have had their radiology and pathology scrutinised, and we'll sometimes do it this way. What we'll say is to the radiologist, is there any variance, and to the pathologist, and if there is not, then we'll mention them and say they need no further treatment, and that's enough. But we do record that. And even doing that, our MDM lasts at least an hour and a half every week. It's very time consuming. And the radiologists and the pathologists are spending, I don't know how long, preparing for this meeting. The other thing that I neglected to mention when discussing our project was that I almost think the most important people at the MDM are the radiologists and pathologists. The clinicians sort of less important, I think.
Yes, thanks. I really enjoyed those presentations, and it's good to see this sort of internal work being done. I just want to say two things. Firstly, that we're very well supported in the cancer area by the ICS program, and so the ICSs can do projects and they can fund projects. So if you have a project like this, there is support available through the ICS program to do this sort of activity. Now, the ICS people might scream at me, but that is a fact. The other thing, which I just, in terms of MDMs, do we ever talk about socioeconomic status in MDMs apart from just passing it by? Because as I looked at most of the data we produced here, SES state or socioeconomic status had a huge impact on both disease occurrence and also disease outcome, I'd guess.
Might be a question for another summit.
I don't think we've ever included that in our MDM discussions.
All right, we've got two more questions and then we might have to just move to the last, a little bit of an exercise before we wrap. Go ahead.
It's been mentioned at this meeting several times that a potentially altered format may be used for MDMs, whereby there may be some patients for noting and others for discussion, and you actually have a two-tier approach to the meeting for efficiency's sake. A question is to all members of the panel: how are you going to maintain the integrity and quality of the MDM outcomes if such an approach were adopted?
I'll start if you don't mind. I still think the radiology and pathology ought to be reviewed, and I think that maintains quality. And I just don't think you can fit it all in if you don't do that. The numbers are too big. So I think the patient's pathology and radiology is reviewed, it just isn't discussed at length.
I think the only way to ensure the integrity would be to audit the findings. But yes, you could have a system where those patients' diagnostics are reviewed. They're not presented at the meeting, but I guess, for instance, the radiology, make sure there's no metastatic disease, pathology, make sure that the reported pathological stage is correct. But I think there is a role for a system like that. Do you mean double reporting?
Yeah, by a radiologist or a...
Well, that sort of is what happens at the MDM anyway. Depending on how your MDM works, the original report may be amended. So, I mean, the MDM does function as a second report.
Zee.
I'll just mention that I think the clinician who put the case onto the MDM probably is in the best position to decide which tier the patient goes onto. And I think we're discussing at our table that there are some cases which were screened with FOBT or colonoscopy and found to have a T1 or T2 cancer, which strictly will need no further treatment after surgery. So well, we want to present all the patients with cancer at an MDT, but you don't technically have to spend a lot of time with these patients. So that's where that, triaging by the presenting clinician, I think is relevant at the point of entry into the MDT. Yeah.
Okay. So
I've got a question for Zee. We've faced the same problems about increasing number of cases trying to be discussed in a short period of time, and putting on extra MDMs has implications for lots of people, and I was just wondering how willing the clinicians were to do extra and have extra meetings, and then how willing were the executive to put resources into that?
It was one of the biggest hurdle we had, because as you appreciate, the surgeons are very busy people. So the med-oncs and the rad-oncs have less in terms of time restriction, because they have to be in the OT and ED and all that. So we had a lot of difficulty with getting radiologists to say yes, they are open to a new meeting, because they are already inundated by numerous meetings, apart from MDTs, the various department, pediatrics meeting, orthopedics, and the rest of it. So that was the main, one of the biggest hurdle we had. I must say that we're very grateful. We had very supportive executive, and they re-looked at the workload on the radiologists in terms of timelines of reporting, and to see if there was some adjustment that can be made on the day that the surgeons were able to come to the suggested colorectal MDT. So that had quite a major impact on them finally saying yes. And us going to the pathologist, we had to look at what other MDTs were running around the region in other hospitals that the pathologist is committed to be present as well. So it was quite an onerous task. I said this in 3 minutes, but the actual work that went on really involved quite a lot of people behind the scene, with quite many man hours and woman hours involved. Yeah.
All right. A round of applause for our panellists, please.